So welcome to this interpretive proficiency test that this month is on PD-L1 clone SP263 in lung cancer. And Roche is very pleased to sponsor this activity organized by CADQAS and PCI. And today it's Dr. Adelina Baltan and Dr. Simona Costache that are going to go into the result and the review of the cases. If you have any question, feel free to raise your hand and ask it loud, or you can also write in the chat if you feel you are too shy. Enjoy the session and thank you for attending.
Thank you, Anne. I hope you will enjoy this and you will learn some practical tips since last time we discussed a little bit more about theory in PD-L1. So we thought about starting with the last case, which was the most challenging.
Yes.
And it seems like it was more controversial among us than the participants.
Indeed, as you can see, between the CADQAS panel, it was split half-half between less than 1%, how we called it negative, and more than 1%, but less than 50, the weak positive one. The participants, majority though, they were in the category of weak positive, 71%.
Yeah, and we decided to put this kind of diagram to show on the left-hand side, to show the distribution of the scores, to show you that the participants mainly score between 0, but they went up to 70 TPS, and we will see the reason, and we'll try to explain what we're seeing. But indeed, most of them were towards the lower end of the spectrum, and we actually opened this case. So for this assessment, we also have an MNF stain and a CD45 stain, because
we've seen it was more controversial and we wanted to bring arguments, but we don't know how much are we going to be successful in this. We'll see. And again, please unmute yourself to interact with us, or if you're shy, write in the chat, and we do hope we'll have as most interactive feedback session as possible. So let's see. Adelina is opening them all to put them really nicely side by side.
I hope we can synchronize them. So here we have the H&E, then on the right upper corner we have the MNF, and then we have CD45 in the lower left. So the idea is to kind of divide the epithelial cells to kind of distinguish them from the immune cells. And then we have the PD-L1 stain. I don't know if you would. So we have a synchronizing tool, but
I think
actually,
let's see if
it seems like it works quite well.
Let's see the H&E.
So this is the reason why it's very difficult, this case, because as you can see, you can have a look at the MNF as well on the right side. There are some strips of carcinoma, but they are mixed with a lot of immune cells, a lot of inflammatory cells. We also have, if I find the area. So we have, just to double check, I think this was
it needs to be a little bit lower, I think. I think here, this one.
Yeah. Okay. So these are the immune cells in the lower right. These are the epithelial cells. I think it might not be aligned well, because this bit, it was supposed to be here.
Yeah, it's the other way around. This one is flipped.
This one is.
I think bottom line is that if you're going a little bit lower on this one, where we can see definitely invasive, like I do think no one there, perfect. Here in this bit, I think no one can argue. I think you should desynchronize a little because this is a little bit confusing now.
And try this one. And go here.
Yes. So, and here we can see on the MNF that indeed these are epithelial cells and there are tumor cells over there. Oh, perfect. Okay. Very nice. So, and we should have a look now on the PD-L1 as well, at least in this area, where on the left-hand side you also can notice a lot of immune cells.
So the PD-L1 here is here, so we can see a little bit of, I think this is the only area that we kind of identified tumor cell staining that was more convincing. And we do have a few cells like this one, I'm not 100% sure it is, but you can see the difficulty. Not to mention that besides the inflammation, most of this carcinoma could even be in situ. So then the significance of this becomes much more important when we try to calculate the percentage, because if you look at low power on MNF, for instance, a lot of it this is likely invasive right here. But again, this one, I think we couldn't identify any. So there's much less left on the PD-L1 slide. And that's another thing, because we can't compare what's on the H&E section and try to calculate the proportion. We need to calculate the proportion in the slide on which we've done immuno. So if you compare what's on the H&E here, which is much more, to these residual, I think this is a residual island, this is a residual island of
What do you think
carcinoma.
about this one, that is exactly like here, this one, that is staining?
So I thought this could be a macrophage or a granuloma.
Well, let's look at the CD45 then.
So this could this be one of them? But
yes, and it doesn't quite look that is staining that much.
Yeah, unfortunately, we can't really. So these are definite tumor cells with immune cells going in. But this one, I don't know. What if it's a blood vessel?
I think let's just desynchronize everything and let's just look at the PD-L1. And we can see it is quite a lot of staining, I think, without even knowing there are immune cells or what is it that's staining. And the next step would be like, let's look more, because this was also our difficulty when we look more carefully, because then we can understand also those people that said 70%, right? Like it's a lot. So in our opinion, these people scored everything. And now the difficulty is we need to find the invasive carcinoma. And it was that little bit on the bottom that, okay, here it is invasive. But like Ade said earlier, we do have the cytoplasmic staining, maybe here some membrane, so this we could score.
So I think for any given cell, we can't even know if is this a tumor cell? I have no idea. Well, I recognize this when I see clusters already that, and here, for instance, you have in the convincing tumor cells, which are these that I can recognize. Here, I don't know. I don't know what this is. The section is not very similar. So we need to understand there's an element of uncertainty. Indeed. Now, half of us said below 1, the other half said above 1. Now, it's important that you look at the clinical context as well. Because, for instance, this is a squamous carcinoma. We know that squamous carcinoma has fewer therapeutic options. And then it's possible that this patient is treated primarily, this was a metastatic site, probably, I have no idea, with chemotherapy and immune checkpoint inhibitors, regardless of if the PD-L1 expression is less than 1 or above 1. Plus, we don't know if this patient, probably we knew at the time when we reported it. We don't know right now if he has been treated before. If it's an adeno, usually they look for targeted therapy in these patients. So upon progression, obviously, they either do a real biopsy to understand the additional mutations or with resistant mutations, and we usually would do PD-L1 again.
Yes, I think the most important, like you said, and most of you probably already know, the threshold that of 1% is important when we are talking already in second line treatment, and especially after it already had therapy. So they already tried therapy and now it failed, and now then it's when it matters if the PD-L1 is added or not. In the other settings, it matters if it's more than 50%. So when you can give the PD-L1 in monotherapy. Yeah. So this is a very tricky case. We were split. The majority did say more than one. Yes?
Simona, I was wondering whether I could make a comment. This is Corrado. I found this case really challenging, and I think I was one of the people that scored it below 1%, because I thought that the pattern of staining was all related to immune cells. And I did not realize that there were single tumor cells in this biopsy. And I thought once you showed us the MNF, then I recognized that some of these tumor cells are staining. And for me, satisfactorily staining with PD-L1 membrane, although, as you said, there was a lot of cytoplasmic staining as well.
The other thing that we don't know, sorry to interrupt you, but if you have a pleural biopsy, then using MNF is a bit risky, especially when you have single cells. I don't know where this was taken from, because you can have many single cells, slightly spindly, not necessarily unlike these ones, that stain with MNF. So I think we need to be a bit careful about that, especially in lung.
Yes, indeed. But I think this case is really quite fascinating because, as you say, the positivity would range between more than 50%. You know, some of these immune cells were staining so strongly with membrane staining that resembled tumor cells and were large macrophage-like cells, in fact, that we could see with CD45. So I think is a really very interesting case that shows why interpretation sometimes is very difficult. But I hope also that people see how perhaps using alternative immunohistochemistry can help in a way making sense. And then it depends on the interpretation you put, because I think one of you were saying we're not really entirely sure if an individual cell is actually a tumor cell or not. We can see that there is a population of single cells there, but there are other single cells that are immune cells. So in the end, you still need a pathologist and an interpretation at the end of this. But a really interesting case that I must say I interpreted wrongly.
Well, I think it's
hard to say.
Yeah, wrongly. I'm one of the people that say more than one. I said just about one. So I did think, like, when it is clear cut between immune cells and tumor cells, and I'm pretty sure it's going to be a case over there where it's a little bit not controversial, but if you're in a hurry and you see a lot of staining, it's a lot of staining, that's positive, beautiful. But then when you're looking, that staining might be necrosis, that staining might be macrophages and things like this. So when you see staining, it might be a little bit of a trap. But in this case, especially because it's from my brain, I found it so intermixed, everything, admixed, the immune cells and the tumor cells, and exactly that you couldn't make a clear cut in between them. My brain said to me a little bit, come on, it must be some tumor cells over there staining in between all of those, because it is quite a lot of staining.
But perhaps I think it would be useful also to touch upon what are the options for us pathologists when we need to interpret these things. And I think we explain we can have some immunohistochemistry to help us, which is right. And I think you were also debating or mentioning the fact that we need to understand the clinical context, because at the end of the day, this may not be very important because it may not be relevant for the therapy line of this particular patient, but we don't know that. We have to find that out. But then perhaps we should also say, well, but could there be a chance to take another piece of tissue? Is there another piece of tissue around that could be an alternative way of getting out of trouble? We'll stain more tumor cells and see whether that will give us an answer. And I think this is the last thing I wanted to say was that this is something that we often say in this interpretative proficiency testing is, in the end of the day, talk to your oncology and say, this is really difficult, explain the difficulties, and then, tell him, I can put you in a position that if you want, you can use your immunotherapy by calling this 1% or whatever it is that was the problem. But please understand that there is a certain degree of uncertainty over this diagnosis.
I think, yes, I think that's the most important. And we will see also in the next few cases, and I think there were some even comments on how are we dealing with these more tricky cases. And like you said, in this particular case, we need to be honest, see what we are, write what we are seeing, express this uncertainty, and in doubt, yes, contact oncologists, contact the clinicians, and see what's the best treatment in the end for the patient.
And yeah, try to always explain why you taking a decision when you score a case, what you are actually seeing. Because for instance, even if you say, oh, I see some staining, but I don't consider this case to be positive at this stage. At least there is a record of saying that, oh, okay, maybe we repeat this test, even if we take a biopsy for some other reasons.
And just to summarize a little bit this case, or just to close up, I do think that these people that did say less than 1% they are not wrong. And again, the ones that they said weak positive, they are not wrong either. We just need to find the middle ground, and we need to say exactly, to bring our own arguments and to make a comment. The ones that did say more than 50% here, I think it was the jump on of, there are many, it's a lot of staining and everything, we scored everything. The non-evaluable, I don't know here. Maybe someone who did put non-evaluable can
maybe actually
say.
These people are right, because how inflamed the tissue was. And by the way, overlapping inflammation can affect this expression and what we see on the slide.
Do you think it is non-evaluable, this case?
No, I mean, I wouldn't disregard it as this, but probably it will need a substantial comment to say,
yes,
we're not very sure.
Okay,
so I think we're going to case number one.
Case one, exactly. We are going 89. We should have it.
Yeah, sorry.
Okay. Should we look first on the percentages?
Maybe, yeah.
This is not the one. Perfect.
Quite a split between over 50% and between 1% and 50%. So weak positive and positive.
Okay.
Under the circumstance that we were very concordant with this one.
Good for us. But it's interesting here to see in the plot, because they were between 25 and 60 almost, so like the majority clustered between these kind of TPS.
So the spread is not as big, probably in numerous cases, but at the same time, we get quite a range if we look at the whiskers. So let's see what this is all about.
Okay. So I'm expecting.
Should we look side by side at them now?
Not necessarily. I'm happy to look like this. If the people want side by side, I'm happy again side by side.
Okay.
Because I think they are seeing it like this. Maybe it's a little bit more controversial. Yeah, we can.
So this is a bronchial biopsy, looks like. Maybe this is intravascular.
Yeah, exactly.
I'm not very sure. Maybe this is invasive. Again, I'm not very sure.
Let's see more. Here, it's fine.
Here
we are happy
clearly
with invasive. It's a lot of tumor cells here.
Either very ugly or the preservation is not 100%. And there's another fragment, but this doesn't seem to have.
Not quite. This
is
more
mostly
normal.
Yeah, it's normal. Okay. Let's look at the 263.
That's the control.
Yeah, we didn't show the control. This is a nice.
I think they know already. We always have the controls on slide. We always check the controls to be okay. And then if we are happy with the controls, then we are assessing the tissue.
Okay. So, should we start with the first one? This one only had intravascular, we thought, but it's possible that these are near
look,
cells.
you have a little bit of.
I think this was the intravascular bit.
Maybe.
So I think
There are a few staining. Okay. Here is more.
here is more, but again, this is difficult to interpret, isn't it? On this side, because they're probably necrotic or half necrotic cells that stain all over the place. But if we look at the tumor cells, I think there must be.
So I think the battle is between less than 50 or more than 50. Because it was it was anyone that said less than 1? I don't think so. I think it was 0.
Can have a look. Yeah, we did have
Okay.
3%. Not a lot.
Again, if maybe it was by mistake, but if it is someone, we are more than happy to discuss. I think, again, the competition is between more than 50 or less than 50.
In a way, yeah. So I'm looking at this membrane staining, which is not very the sharpest. I think the cells weren't excellently preserved.
But would you not score that?
Yeah,
that
absolutely.
cell?
Yeah, I would score them. But in terms of sharpness of staining,
Yes.
yeah, we need to find an example or two where we say, oh, this is definitely membrane staining, and then we can. But I agree, it's definitely over 1%. And I don't think we can reach 50%. The first fragment was definitely less. Well, you can say this has much less carcinoma, so it's not going to have a big weight. Here again, not a very good preservation, but I think we can identify a lot of tumor cells that don't have staining. And then the last fragment, even here, is almost nothing staining. So
I think when you look at the H&E, you need to see let's not call it the percentage, but because if we are going again percentages and everything, like a lot of mathematics, that's fine. Who likes mathematics, that's good. But it was the tissue, and how much of that tissue was tumor, because it was almost from one went to the other. Now the trick is here, and I do think it's the same as the ER who's scoring breast cancer. So it is immunohistochemistry of estrogen or progesterone and things like this. We have a tendency, because when we see strong intensity, strong staining, our eyes are picking it up. Oh, that's a lot of staining. But then when you zoom in, you realize that from 10 cells, you have 2 cells that are staining, but strong. So then we have, it's a lot. We think that it's a lot. It's not that a lot. There are still 2 cells, strong, which is good, but it's not that much. And here, how they put very nicely side by side, this fragment, it's full of carcinoma. And if we're looking exactly at the cells that are staining, there are not that many. And I do agree, it will be something like 20, 30, 35.
Yeah.
I don't know.
But also, Simona, I would say that there are a lot of tumor cells staining, but almost all of them are cytoplasmic staining. You're going to struggle to demonstrate to us those cells with membrane staining. They are there, but not very many.
Yeah, exactly. So, and I was thinking, looking at it now, that because you were the one scoring this case and you originally scored it much lower. And I'm thinking, we do a lot of extrapolation. Like when we see, okay, this cell has perfect or very good membrane staining. And then we think, oh, then there must be that the others also have membrane staining. And they're actually non-necrotic. And that's why they pick up chromogen. So I think I would definitely call it positive, but in terms of percentage,
yes,
I think there's a wide range where we can go because of I think it's quite poorly preserved, which is surprising for bronchial biopsy. And the staining is not sharp.
Yeah, so I'm pretty sure that there will be those of us who will raise the question, why are we not using image analysis or some sort of computational thing to count all these cells? But I also think that the staining pattern that we see is not one that is easily associated with those that have reached 50% plus positivity. This is a tumor that struggles to have positive tumor cells. So I think we should also learn a little bit about the pattern itself rather than being hung up on these numbers. Of course, they're important, but there is not the only thing.
Indeed, yeah. Yep, completely agree. Yeah, yeah. Case 2. More split here, but in between less than 1 and the weak positive one is there, and you can see also from the image how we are going between 0 and 40, but the median it's a 10 though, so it's not that
very many in the over 50 as well. 15% is significant, and we see this is the outlier value, so someone call it 100% under the circumstances that most people thought between less or above 1. So that's case 93.
Sorry to interrupt again. I should mute myself forever.
No,
There is somebody,
please.
Lina in the chat says, so to clarify, you disregard the cytoplasmic positivity and take only membrane positivity. That's a question.
What was just cytoplasmic?
Just membrane.
You disregard cytoplasmic positivity.
Yes. I think Ade and Corrado had the presentation about the PD-L1, but like the theory of the PD-L1 for SP263 a couple of weeks ago, and it is on YouTube and it is available. So please, if you have time to look at it, but just to summarize and to ask the question, yes, just membrane staining, no nuclear staining, no cytoplasmic staining, only membrane.
But does it mean that if a cell has cytoplasmic staining and membrane staining, you say is negative cell?
Well, if you can distinguish the membrane staining from the cytoplasmic, then you will still count it. Some cells, and especially with more anaplastic tumors, they do tend to show cytoplasmic staining on top of membrane staining or cytoplasmic staining in isolation. So you need to see if you can distinguish, just like with other, let's say, membrane markers, including HER2.
Yeah.
But we can count positive cells if they show both cytoplasmic and membrane.
Yes, yeah.
They would count. Yeah, thank you.
Thank you.
So I have to say I like this split for this case, because this is a case I reported. So this was a relatively small tumor in the lung. So we tended to do biomarkers on all the excisions, whether they were the very localized small lesions that at the MDT will tell you just surgical follow-up. But this one had a strange finding for such a small lesion, which was vascular invasion. So most of your tumor looks like this. I think there's more desmoplasia. Can't remember. Yeah, it was more superior to that focus that I'm going to show you straight away. So this is definitely invasion. You have also a lot of so-called lipidic pattern towards this side. But even here, you can argue that the septa are thickened. And then you've got this area, which this was part of the tumor had more slides that were more suggestive of vascular invasion. But you can see a little bit of the elastic, I don't know if it shows very well, of the elastic lamina all around. So this was intravascular carcinoma, but with desmoplasia. And it's kind of, to be fair, inside the tumor. And let's have a look at PD-L1. A lot of color at first sight. So
now I understand why people said more than 50.
Yeah, that's the tricky case where you can see all these macrophages inside the lumens. I don't know, the counter stain is not very strong, but if you look carefully, these are your tumor cells all around. And there are a lot of immune cells. So by the way, sometimes we have the impression that it's tumor cell staining, but it might be from place to place. Maybe this is a tumor cell and maybe this is not entirely necrotic or degenerated. You have a little bit here, maybe. This looks inside the lumen, but this one is more at the periphery. Again, a lot of immune cell staining, either in the middle of the glands or even in the stroma. This one, again.
You have occasional.
There's a lot of macrophages inside, or probably dead tumor cells as well. Towards this side, it was much more negative. It was mostly in the immune cells and the foamy macrophages inside. And I don't want to get you bored with this, but if you go at this area, which I ignore from my initial assessment because I thought this is a different compartment, it stains much more.
Yeah.
What is going on here? I don't believe this. But this is staining. So if you add this to your assessment, you probably have, I don't know, 3-4%.
Even 5.
Even 5%. But if you ignore
That's
this,
quite a lot.
The problem is the rest of the tumor, except for this area that has a few cells, is negative. So then what I written in the report, I said there's some intravascular carcinoma that I don't know if I should score or not. So I call it actually less than 1%. I counted the carcinoma in the lung. So now, honestly, I think it would have been because if we think that the vessel is inside the tumor, it has desmoplastic reaction, although that desmoplastic reaction is coming from the blood vessel, let's say internal structures, probably should have been counted and call it over 1%, but much less than 50%.
Yeah. I do think that all of these that are definitely tumor cells and are staining. I think the rule of thumb on this case and take home messages, whenever you're seeing staining, just zoom in on your microscope, zooming on the digital slide, zoom in on that staining and see what is staining, and compare a little bit with the H&E, because in this case, that's why the majority, pardon me, said more. Did they say more than 50? No, not majority, but
significant.
Yeah, proportion said more than 50.
And you can see why, because if you don't look closely, these look like cohesive clusters, these macrophages inside, and it's sometimes very tricky. I mean, this is an excision. It gets even trickier on a core biopsy.
Yes, exactly.
Where you have these things intermingle and you don't understand if this which side of the tumor, the periphery. We usually see them at the periphery, but because this carcinoma has a mixed lipidic pattern you have quite a bit of these inside the tumor. And then there are no rules telling you in reality how you should score if the tumor is intravascular, whether it has desmoplasia or not, whether you should include it in the score or not. But I think probably you need to make your own judgment and decide.
I think in this particular case, like you said as well, the desmoplasia, and it's not just like we had the previous case, a little bit of intravascular. It is quite big, and it's a large good amount of tumor. I think I think we can score it, and we should.
I think you used the right wording.
We can.
We can.
But like you said, you need to filter it, you need to make your own judgment, and you need to put everything together in the context. Don't take things out from the context. Okay, let's go on. Again, if there are any questions, please. We do not, I think Hannah is keeping an eye on the chat and she will let us know if anything But please either write in the chat or unmute yourself.
What do you think about this one?
This one, which one is case 3?
About just only above a third agreed with all of us, which is over 50. And then 60% thought between 1 and 50%. But again, it's not the
yeah,
huge...
exactly. If you're looking, the median is 45 though. So
yeah,
is there? It is 94.
Okay, looks like a small biopsy.
We like small biopsies sometimes. Sometimes we don't like them. That's the problem with the small biopsies. They are not that. Yes.
But we can see the tumor pretty well. It's quite inflamed though. Whatever you like to call it, immune infiltrated.
But still, you do have quite a lot of tumor. And when I'm saying a lot of tumors, you don't have gaps. So in the core biopsy, you don't start having, okay, tumor, then nothing, then again tumor. That's a little bit more tricky. Whoever sees prostate will understand what I'm saying with when you need to make the measurements and the percentage, how much of the carcinoma. It's similar. It's exactly like this. How much do you have? How much carcinoma it is there? So you need, before even looking at the PD-L1, you need to have this.
And it's horrible for when we do SP1 for 2 because we need to refer to the area. Usually with biopsy, we refer to the whole biopsy area, but in any case. Okay, we need to see a lot of staining then. We expect a lot of staining.
Okay, we have a comment where the specimen is a snapshot of a tumor state at the point of excision. Intravascular positive tumor will likely be positive at the distant site if not excised. Treatment is surely based on potential for therapeutic effects.
Thanks for the comment. I know
it is a good comment, but
it's difficult to tell. Do you think? Do we have data about this? That
I don't know what to tell you.
Because I'm also thinking that there was a lot of reactive process going on inside the vessel.
Yeah.
So
interesting comment. Thank you.
Hopefully they would do another biopsy.
Yes. Well.
Okay, so
back to this one. You have staining. Is it membrane?
Some of it definitely is. But my question is, what do you think about these ones? So this is definite.
I think it is weak, but it is membrane.
Yeah, I think, but the cells are quite cohesive. They're okay. So I think we can tell that even this weaker staining is tricky case because you also have a little bit of cytoplasmic blush plus these cases. What magnifications are we on?
20 now.
Now
now
we're
40. Quite high now.
Quite high.
I mean, for example, here I wouldn't call this membrane. This one I would call it membrane.
Yeah, I think it has enough brown, and it looks like real staining rather than just the interface. Like here as well. I'm not very sure about what's going on here.
If you're not sure that it is membrane staining or not, at 40 magnification, you should not call it membrane staining, or you should really consider not to call it membrane staining, not to be so advocate of no or yes. I think our eyes are playing a little bit, and it's also this blush all over the place. So no, it's the same with the HER2. Just don't go into that even more than 40.
Again, here you see that cytoplasmic stain. So probably you have a lot of necrotic cells, especially in lung tumors. So don't jump on calling any staining something.
Yeah.
But I think here in this case, we demonstrate a lot of, even here, now I'm not at 40 anymore. I was at 20. So I think this must be real. And if we go a bit higher at 30, you can still see it. And again, you have a mixed also the immune cells. Maybe a lower power, you see the immune cells better than the tumor cells. So you need to go closer up. Sorry, you were about to say something.
Well, I just wanted to highlight that you do not need circumferential membrane staining. You do not need any of these. You just need a portion of the membrane to be staining, but to be clear membrane staining over there.
And again, this is an important point also, because if you have only partial membrane staining, you can also underestimate the staining.
To disregard
and
it.
For instance, this area here, and you need to count the cells that are around, or let's say touch that portion of cytoplasm. Those are also positive cells. So if you have staining between 2 or 3 cells, all those cells are positive.
So it is quite a lot.
This one, definitely.
It is a lot. And again,
you have clusters where almost, this cluster, for instance, is almost all the cells.
Almost.
You have
and especially
going on.
Exactly those cells, it's weak membrane staining, but it is membrane staining and it is scorable. So you need to take this in consideration. Can you show me again the split on the percentages, please? Okay. So that's why, because I was thinking, I hope we did call it more than 50, because I was looking at it again. That's why I think we were in agreement with everyone, and we said bottom line more than 50. Now it's not 100, but yes, it is more than 50.
So from this case, it's basically.
So this is another difficult case, and I think the correct interpretation hinges on the fact that we need to take into account very weak membrane staining, partial. And I think everybody should remember the amendment to the interpretation guidance, which talks about convincing membrane staining, which is a word that we should reflect upon. So it's a membrane staining that you as a pathologist think is membrane staining. So as Adelina and Simona was saying, you can magnify to smithereens and then starting to see things, but normally you would see membrane staining at times 20, and then you probably put times 40 to make sure. But when you don't see at times 20 and you only see at time 40, you need to ask yourself, do you believe it?
Real,
what you're seeing? And I think those, because I think here the majority scored below 50%, just below 50%. And I think maybe there was, most people did not believe in that little weak membrane staining, partial membrane staining in a lot of these tumor cells. That was but I think if we were to score it, we would score it probably just about 55% or something like this. It wouldn't be way more than that.
To comment and to answer also the question in the group chat, indeed, and again, I'm going to stress out the importance that these are digital slides. It's very important, the laptop that you're seeing it, the computer that you're seeing, the resolution, how good they are. Again, I said it in the previous, whoever followed us knows, almost all computers are going to pass. It's a test on the internet that is it good, your laptop, to report. Yes, all of them, they are brilliant. They are not, unfortunately. And we have evidence very clear where I couldn't see not even one line on my laptop, and then on the laptop near me, there were clearly lines. So sometimes it's not the participant's fault, it is the laptop fault. And just to say the comment, it is possible to receive a range of TPS values assessed by the expert panel. I think yes. I know we have the data, but I don't know how difficult it is for our organizers to give you this data. For this case in particular, we do have, it is around 55%.
I think I call it 55.
It is possible, but also it's probably good to observe the median value of all participants. So these are, maybe we should say that those whisker plots, box and whisker plots, are the median of all people that declare themselves as reporting PD-L1 and they participated at this. So if you want, is an expert panel, if you want, but it's external. And the other one is CADQAS panel. It's slightly different. So on the median of the expert people that looked at this was 45%, something like this. So as you can see, this is a case that is really, really close to the borderline. So I don't think anybody should get too upset about having scored just below or just above this number. It's clearly a borderline case.
And I did struggle a bit with it, I remember, because at first, again, I had the impression I was trying to convince myself about the weaker staining, and I just call it just over 15%. Right, next.
Okay. This should be a straightforward case.
So most people thought between 1%.
90% of the people thought that. So we are really
This is the best case then.
Yeah, exactly. This is 118. Good.
Okay.
Good.
So this is a biopsy with lung tissue. So we need to be careful about what's going on around. But the tumor is quite clear. It's quite ugly. I thought when I looked at it that it has this glandular component. And as you go along, it gets much more uglier looking. It's turning into some sort of anaplastic kind of tumor. Like this is the features you would see in that. And then it becomes glandular again. So sometimes you see, depending on the component of the tumor, you see different levels of staining. Again, here is mostly necrotic. I assume this was necrotic tumor.
Yep.
Then again, you have a little bit residual, then necrosis again. Just what Simona was saying.
Be careful
tumor,
with
no
these,
tumor.
Be careful.
And then lung tissue with, again, a little bit of carcinoma. And this probably is normal. Okay. But this should be very easy and easy to interpret. Okay. So we're on to the glandular component, not very exciting. Maybe there is a little bit here. Few cells, immune cell staining. Again, maybe.
Looks a little bit cytoplasmic there. There it is going to be a little bit debatable. Are there really some membrane staining? And you might think a couple, but you do have some cytoplasmic staining.
But
beautiful.
As we move on to this uglier area, then you see a lot of membrane staining. You see how ugly the tumor cells are. And in these kind of tumor cells, you tend to see cytoplasmic staining as well. And I think we can look, this is a horrid, huge tumor cell. We're missing a bit here because we went too deeper in the tissue. And look, these are tumor cells actually, without any doubt, because you have giant cells, but they have ugly nuclei. And this is, in these areas, is almost, probably is over 50% in these ugly.
Yes.
But then we go again to these areas that do not stain very much. So probably is also matter. Just this is also a bit more anaplastic.
Pay attention, then those giant tumor cells that Adelina was saying, they are big. They are big, so they are occupying a lot of area-wise, but it's only one. And in the same area nearby, that one giant cell equals 6 or 7 tumor cells that are negative. So pay attention of these when they are starting being with different dimensions and different diameters.
This is a very good comment because we usually are very visual about these things.
That's
but
the
if
problem.
We have different components that have different cell size, then it's much more difficult.
From low power, literally, you have this bit that even you could say, oh, it's almost 100%. Everything was staining here, and this bit, but you still had tumor here. You still had tumor here that you're almost not seeing anything. Well, you could see if it is weak, but we can't. We already know because we zoomed in and we've seen is nothing over there. And you still had here and here.
Yeah. So it's true that this proportionally, because it's almost all of it tumor.
So you can always zoom in. see, okay, that this part I had some staining, but it was weak, so I'm not going to see it when I'm going to be high, on a low power. But when you already zoomed it, you've seen there is almost no staining over there, and the staining that I have, it was in this portion and in this portion. Zoom out and then see how much tumor you have, and then that will be your percentage. So it's not hugely, it can be even more complicated, but we are trying to make it less complicated.
So in terms of tumor area, this would be, if you think that this doesn't have too much tumor, the staining areas would be probably even half, but the score will be lower because your tumor cells are bigger. So you need to.
But everyone was happy with this case. So we are also happy with this case.
Okay. Should we look at the next?
Yeah, I think it's the last one. This one. Good. Again.
This is almost as good as the previous one. Most people thought it was below 1%.
But people said also a few, 119. A few said more than one.
So yeah, 12-13%. Okay, so this is your nicer adeno. This one, the tumors are the tumor cells are very uniform. I don't think.
And again, it's almost everywhere tumor.
We'll have any difficulty identifying them. Okay. So far, so nothing. These probably are inside the gland.
Lumen.
And in any case, they don't look very viable. That's the other thing. Make sure you score viable cells once again. Again, I don't know the significance of this. If you show me one cell that is doubtful in a sea of negativity. Again, these have more like macrophage staining pattern, don't they?
And they don't have this, I would say, is no membrane staining. It is only cytoplasmic. Yes. And on lung, I would make this comment. Be aware what it is inside. When you see like the lumen, you should not score it there. Look again on the H&E, because they're not just some tumor cells floating in the lumen.
Exactly.
I mean, you could, the intravascular, but no, usually they're the macrophages, usually it's the debris, usually there are things that we should not score for the PD-L1, the 263.
Of course, you need to make sure it's not micropapillary, but this is not one of those cases that maybe here, what do you think? But there are 1, 2, 3, 4, 5, 7 cells.
Please.
I think, Adelina, what you're showing is macrophage pattern.
Yeah, exactly.
And I think we need to learn the pattern of staining. This is not tumor cell staining.
This is,
if you zoom in higher power, you will see the nuclei are paler and they are a little bit
yeah, I find it hard, I have to say, because the nuclei of the tumor cells are not that large. I mean, these to me are more clear macrophages than these ones here.
Yes, but don't you see that they are paler nuclei than the ones?
Yeah. This one.
Yeah, I think so. Because I think, look how you're coming with the lumen. It is here. So, yeah. Anyway, even if those cells would be
assume that
tumor cells, I still feel like we are going to shortfall for.
Absolutely, yeah.
So the ones that I think they scored more than one, there were those macrophages inside, and the only staining that we have.
Yeah, and it's possibly that they added out all of them, because if you thought those 7 cells were positive, it would still not be enough. And another area was here, maybe of confusion, but this is much more clearer, detached from everything else. And here you have only cytoplasm.
Yeah. Okay. Let's see also the next slide where we have some comments. We often get very small biopsies with limited tumor cells. Do I comment on PD-L1? Just say not enough tumor volume. What do you think, Adam?
So I think it depends on how many, but I think that this joins up with the last question.
regarding the number of cells, what is the absolute minimum cutoff point? For example, would less than 10 cells be enough, especially if all are positive?
So because in lung we get a lot of cytology specimens that often suffer from that. Usually when we have core biopsies, everything is good. We usually have enough tumor cells. What I would say is, even if you have less than, the cutoff point will be around 100 cells conventionally. But if you have, let's say, 20 cells or 10 cells and they're all positive, we know that it could amount, if you would have 100 cells, it could amount to at least a TPS of 1%. And then I think we need to mention that, and we need to, me personally, I did score cases that had fewer tumor cells. The problem is when they are negative, and that's when you don't want to call a case negative if it isn't. So we usually recommend we call these cases indeterminate, because we use the TPS score with this PD-L1 test, and it's much easier to use cytology specimens. And we did have, in the cases that we tested both on core biopsy and on cytology, for the reason of indeterminate molecular results, usually, we did have good concordance. But
I think the easiest way out is make comments. Yes, always make comments.
I think it would be worth to note that in the clinical trials, specimens were not evaluable if they had less than 50 cells, depending on what antibody they use, either less than 50 cells or less than 100 cells. So we do not have data that shows that a smaller sample doesn't respond as well as a bigger sample.
Exactly.
So there is no basis on this threshold of 50 or 100 cells.
Yeah, exactly. Make comments always, even if you have 5 cells. Don't call it positive, call it this might be positive, this could be positive. Always suggest to be repeated on additional sample if available, and make the comment, there is very scant tumor cells, in brackets, this amount, 5 cells, 10 cells, how much do you have? However, all of them are positive. So the clinician will know, the oncologist will know. And the other way around is negative. However, all of them are negative. And like that Ade said, indeterminate. Then I will go more for with negative, indeterminate, repeat on further biopsy if available, or an excision specimen with the comment that the ones that you have, they are all negative. Yeah. And then is the comment about using CPS. We don't have CPS with lung, but when using CPS, I assume with a different PD-L1 clone, do we consider only the inflammatory cells directly related to the tumor, or can peripheral aggregates also be included? We have 2 more minutes.
Again, it depends.
Bottom line, very tricky in lymph node. That's the biggest challenge with the metastasis. We are using the 20 times rule magnification. You have the tumor, you're putting the 20, whatever it is in that your field that you are taking into consideration.
In the lymph node, preferably the cells that touch the tumor.
Yeah, that's
rather than, depends on how well you can assess the architecture.
But why are we talking about CPS?
Because it was a question, but like this, maybe we open their appetite for the next talks where we are going to have the CPS.
Okay.